just to be mindful of all of your time, because I know how busy everybody is on a Sunday. So I wanted to thank you all so much for joining us today for our panel. My name is Jen Margalis, and I am the project owner handling our clinical panel series at LARVOL. And I want to just take an opportunity to first introduce our wonderful panelist speakers that we have for our discussion today. So our moderator is Dr. Shilpa Gupta. Dr. Gupta is the Director of Genitourinary Oncology and the Associate Professor at the Cleveland Clinic Cancer Institute. And our panelists are Dr. Deepak Kilari, Associate Professor and Director of the Phase 1 Solid Tumor Program at the Medical College of Wisconsin. We also have Dr. Bradley McGregor, Clinical Director of the Lank Center for Genitourinary Oncology and instructor in medicine at Harvard Medical School. Dr. McGregor is at the Dana-Farber Cancer Institute. So thank you so much to all our panelists. We're really excited to hear from you as you discuss the impact of these selected GU abstracts from the most recent ESMO 2121 conference. So with that, I will hand it off to Dr. Gupta.
Thank you, Jen. Welcome, Deepak and Brad. Really glad to have this panel discussion with a very exciting ESMO meeting that is happening, and these select abstracts for us to discuss. So we'll start with the first abstract, which was the conditional survival and 5-year follow-up in CheckMate 214, first-line nivolumab and ipilimumab versus sunitinib in advanced renal cell carcinoma. And I'll hand over to Deepak to introduce this, and then we can moderate a discussion around it. Deepak.
Thank you, Shilpa, and thank you, organizing committee, for having me over here. So today I'll be presenting abstract 661 that Dr. Motzer and colleagues have presented at the ESMO meeting in 2021. And what they did a little bit differently this time was not only did they look at outcomes for patients on the CheckMate 214 study, with a 5-year follow-up, but they also looked at outcomes based on conditional survival. And I think that's really interesting and unique in this day and age when we have IO VEGF combinations being that are approved and are in clinical practice to sort of see if we can differentiate this versus other groups. So as we all know, CheckMate 214 established the role of ipilimumab and nivolumab for patients with advanced clear cell renal cell cancer who have both intermediate and poorest disease. It was a phase 3 study that took patients who had advanced renal cell cancer, a clear cell component, and untreated patients. And patients were randomized to ipilimumab and nivolumab. Ipilimumab at 1 milligram per kilogram, and nivolumab at 3 milligram per kilogram every 3 weeks for 4 doses. And then subsequently, patients got maintenance nivolumab depending upon their response. And the opposite arm was sunitinib at 50 milligrams, 4 weeks on and 2 weeks off. Based on the data that was presented in 2018, the study, the combination was approved and it became the standard of care. So it was the first phase 3 study that established the efficacy of immune checkpoint combination. And over the years, Dr. Motzer and colleagues have been presenting data looking at 2-year follow-up, 3-year follow-up, and more recently, even 4-year follow-up. What this abstract does is basically it looks at outcomes at 5 years for patients on the CheckMate 214, but it also looks at patients looks at their conditional survival. In other words, conditional survival, from my understanding, is basically what they do is they take patients at the 3-year follow-up point and they sort of like reset the clock, and they estimate the probability of remaining alive in response or disease-free for another 2 years from that 3-year mark. So as you can see here, based on the data that was presented, even at 5 years, the survival benefit was maintained for the intent to treat population as well as the intermediate and the poorest population. The data is not shown in this poster here, but clearly in the poster, the benefit in terms of survival was clearly better with the ipilimumab and the nivolumab group. Similarly, in the outset, there was really no PFS benefit, but as you see with time, especially at the 5-year mark, there was a splitting of the curves, and there was actually a tail or a plateau at the end of the curve, where the 5-year PFS probability was 30% for the intent to treat population. And this also was maintained for patients who had intermediate and poorest patients. So clearly, with longer follow-up, the authors have been able to show that there was both a survival benefit as well as a PFS benefit. So going on to the second part that they did was they looked at conditional PFS, OS, and responses. And what they did with that was basically, again, as we pointed out before, they took a 3-year follow-up as a time point, and then they sort of like reset the clock on the 3-year. And clearly, ipi/nivo had a better outcome in terms of conditional survival, conditional PFS, and conditional response. So all the outcomes favored ipilimumab and nivolumab, even with longer follow-up, and patients who had disease stabilization at 3 years clearly had good outcomes even at 5 years, and this was maintained for this group compared to the Sutent group. They also look at quality of life data. They talk about a safety profile, and they say that with a longer follow-up, there was really no new safety signals, and the quality of life also favored ipilimumab and nivolumab based on the FKSI as well as FKSI-DRS scores. So the abstract basically suggests that this is the first time they've looked at 5-year follow-up with any immune checkpoint combination. I think this is the only data that was ever presented that looked at 5 years. This is the first time they looked at conditional survival. The benefit of the ipilimumab and nivolumab was consistent with what we've seen in previous subgroups. And the safety data was encouraging, and there was really no extra side effects, and the health-related quality of life actually benefited or favored ipilimumab and nivolumab compared to Sutent. So the authors have to be congratulated at actually being persistent and looking at data, following up these patients up to 5 years. And with that, I will stop.
That was a very nice overview, Deepak, and really commendable work by the entire Checkmate 214 team. Now, as you know, this was the first immunotherapy first line that we started using a while ago. So where do you place this combination now when we have multiple checkpoint and TKI combinations? And another question I have is, like, in the past, we were using ipi/nivo for intermediate and poor risk. And based on this, would you also use it for favorable risk, even though FDA approval is for intermediate and poor? So if you want to comment on that, and then I'll have Brad take those questions.
So it doesn't change my mind. I think ipi and nivo still has a place in management of metastatic RCC. Yes, you're correct with the approval of Cabo, Nivo, Pembro, Axi, and then Pembro coming. We all know that they're pretty effective regimens, but again, we have pretty robust follow-up data with ipi/nivo. And in my clinical practice, ipi/nivo still has a place. For patients that have rapidly progressive disease and bone disease, I probably would go for a VEGF IO combination. Whereas patients who have slowly progressive disease or low volume of disease, I think ipi/nivo is still a very good, reasonable option, especially given that after 12 weeks of ipilimumab and nivolumab, patients go on maintenance nivolumab, which is much better tolerated than a VEGF IO combination. Regarding your second question as to whether I would use this for good risk patients, I am not 100% convinced that I would do this. Even though the data says that there is a benefit for the intent to treat population, clearly the survival benefit was not in, I mean, if you look at the favorable risk patient, there was really no survival benefit. And with the VEGF IO combinations actually, or even a single agent TKI, I mean, one could argue that a single agent TKI has been shown to be pretty effective in these good risk patients. So I think with the discussion of the patient and patient's comorbidity, I probably would even consider a single agent VEGF agent or a VEGF and IO combination over IO, unless patient cannot tolerate any of those two options.
Thank you, Deepak. Brad, your thoughts on the data and where you place this, especially in all comers and favorable risk patients?
I mean, I think this is really exciting data. I think this is like extended follow-up for this combination. I think there's really a hope that there may be a tail to the curve. And I think that's what these conditional survivalists are trying to show us, that, if you do respond and you're in that fortunate group, that 40%, the chance you can maintain that response seems to be high. And that potentially that we may, maybe we are curing these patients. We never know for sure, but there's this hope that maybe by being aggressive with this therapy, we're going to lead to a really prolonged disease-free survival and potentially even a treatment-free survival, because we know that we can stop immunotherapy and often patients maintain their benefits. And, obviously you never want cross-trial comparison, but I think, this median overall survival intensity to 55.7 months versus 38.4 compares very favorably with what we saw from pembrolizumab, which was, just over 45 months versus 40 months. So, obviously trial comparison, but the sunitinib arms seem to be comparable. So I am really excited about this data. And I really do think, I agree with Deepak, this has a role in the management of patients with advanced clear cell disease, especially if you can afford to be wrong, right? So the response is 40%. There's a 20% progressive disease, but if you do respond, it can be really durable. So it can be worth a shot. And I think it can be worth a shot, even those patients with favorable risk disease, because we know even among those with favorable risk disease, there's patients who can have those really good responses that can be durable. And we saw with the extended follow-up here, the survival of the favorable risk disease patients was 74 months versus 68 months. So not statistically significant, but certainly very appealing. And if you look at all the TKI-IO combinations, it seems to reverse with time, the hazard ratio looks worse. So I think with extended follow-up, it does suggest that maybe there's this tail to the curve and that there can be independent of their risk group. So I think this really does establish the role of Nivo/Ipi in the frontline setting with potential for a tail to the curve. And I think what we need to do, hopefully, is build upon this. And so I am excited for trials such as Cosmic. We're looking at, can we add Cabo up front, and can we get more of these patients out of that 20% PD and stabilize disease such that they get that durability from ipilimumab? So I'm really excited about this data. I think this data makes me feel comfortable, independent of risk classification, discussing this option with my patients. I'm not saying they should get this without a doubt, but I think it does provide a new level of data that really does make this appealing across risk groups.
Yeah, absolutely. And even in my clinical practice, I would say around 40–50% patients get Ipi/Nivo. And, we know from other trials that introducing Ipi later is not as good as upfront. And it makes sense to have patients get the most beneficial therapy during their journey. So you're absolutely right. This data reinforces that. And it's really great to see all these options that set the stage for this, especially 5-year follow-up. Who would have thought that at 60 months, around 50% patients will be alive? This is really tremendous.
Yeah, if you just think about the initial IMDC criteria, right? Those are favorable
Right.
disease. They were like median survival was 48 months. And now here we are talking about in favorable disease, median survival is 74 months. It's just amazing how far we've come with our therapies and continue to evolve.
Absolutely. And I think we'll move on to our next abstract, Brad, that you will discuss in the interest of time. So the phase 3 CLEAR trial in advanced RCC, outcomes and subgroups and toxicity update, Brad.
Yeah, so we've seen this data presented. This was a large phase 3 trial that was looking at actually 3 different comparator arms. So lenvatinib with pembrolizumab, lenvatinib with everolimus, or sunitinib. And the data has been presented previously, has been published. And lenvatinib pembrolizumab really had remarkable activity with a hazard ratio for the PFS of 0.39, under 0.4. I didn't know they went that low, with a remarkable improvement in overall survival across risk groups. And that led to the FDA approval of lenvatinib and pembrolizumab for patients with advanced renal cell carcinoma in the frontline setting. But when we think about this, as we do with all of these, now we have all these different TKI-IO combinations, IO, is trying to look at these different subgroups, these different populations of patients that you may be seeing in the clinic, and how does that data apply to who you're seeing in the clinic? So this was a post-hoc exploratory analysis, really looking at the outcomes for len/pembro versus sunitinib in some different subgroups, specifically ones we think of that may be associated with worse outcomes, those with baseline bone metastases, baseline liver metastases, as well as presence or absence of a nephrectomy. So with the Carmina data, obviously nephrectomy in the front line has sort of gone away. But we do know that if you have the primary place, outcomes seem to be worse. We've seen that across trials, as well as sarcomatoid, which we know historically has been very resistant to VEGF, but more and more maybe even predictive of benefit from IO. So they went back and looked at their groups, and they looked at these different patients. You can see the numbers of these groups are relatively small. You know, the sarcomatoid patients, less than 30 patients in the len/pembro arm. But what they really showed overall was that independent of these prognostic factors, also looking at PD-L1 status, there was a benefit for len/pembro versus sunitinib in both PFS and overall survival. So independent of these different benefits, without a doubt, that was seen. And we can see that when they sort of summarize this in odds ratios, looking at lenvatinib plus pembrolizumab versus sunitinib in these subgroups of interest. So across the board, there was activity of len/pembro over sunitinib in these different groups. They also did a toxicity update. So in the initial analysis, they presented some data just showing about how many patients needed high-dose steroids. That was about 15%, which required a dose of 40 milligrams or higher of prednisone. But that actually requiring for less than 2 weeks, from over 2 weeks is actually much less than that. So just highlighting the safety, for at least from an immune-related adverse event profile of this combination. So I think this data certainly further cements the role of len/pembro as an option in the frontline setting for patients with metastatic renal cell carcinoma.
What are your thoughts on the toxicity, given this was a higher dose of lenvatinib that we typically use in the refractory setting? And
the dose of lenvatinib is like, you know, if the monotherapy we have from the randomized phase 2 is 24. When we look at len/ev, we use 18. And then here we're using 20. And with this, you start 20, the first dose reduction is down to 14. And we saw from the initial presentation in the New England Journal paper that patients needed dose reductions. This is certainly of concern. So I think it's one of those issues. Is 20 the best dose? That's the dose that was studied. So I think when I've used it primarily on trial, start with a 20 and just be quick to look at dose reductions. The toxicity profile does seem a little bit more toxic potentially than some of the other regimens that are out there. I think what distinguishes something like cabo-nivo from this is cabo, you actually get to start at 40. You're starting at a lower dose, you do it monotherapy, which I think may lead to some of their quality of life improvements. But we have seen quality of life, even with len/pembro, was not inferior to sunitinib, even starting with this 20 milligram dose.
Yeah. And what kind of a patient, and I know these are post-hoc analysis and very small numbers, but it is reassuring to see that across the board, this is, compared to sunitinib, it is obviously better. But when you're looking at a patient, what kind of a patient would you choose len/pembro versus ipi/nivo or cabo-nivo or pembro/axi, for example? What percentage of patients do you use this in?
So I generally prefer nivo/ipi in my patients just because I really feel it's hard to salvage with ipilimumab in that later line, and there's that chance for that durability. So if I have a patient who I think I can afford to be wrong, and if they're in that 20% progressive disease as best response, that I'll be able to salvage them with second line cabo or len/ev, then I'll sort of start with nivo/ipi. I will say if I have a patient with sarcomatoid histology, I'm going to look to nivo/ipi in that setting, because there not only was nivo/ipi better, it seemed to be better if you had sarcoma or not, right? The response rate went from 40 to 60%, CR rate went close to 20%. And if you look at the outcomes, obviously small numbers, the PFS was markedly different for the nivo/ipi versus something like len/pembro. So I do think about that in that situation. But if I have a patient where I need a response and I'm worried that if I don't treat them now, they're not gonna get there, I think something like len/pembro or cabo-nivo, both with PD as best response less than 6% is certainly very, very intriguing. And then it just comes down to a discussion with the patient about toxicity profile, comorbidities, what makes the most sense.
Absolutely. And Deepak, what do you take from this data? Would this make you change your practice towards using this more than other regimens? If yes, what is the highlight of this data, and what are your concerns or practical challenges?
So as Brad pointed out, this data reassures me that len plus pembro is a very effective combination. I mean, like we've all had questions when the first len plus pembro data came out. Is the efficacy good in the good intermediate and poorest patients, because it was all lumped together, and then the subsequent analysis showed that yes, it was very effective even for the good patients, intermediate and the poorest patients. So I think this data reaffirms that it is comparable and equivalent, comparable to what is out there with Cabo Nivo. And I think one of the things that we always sort of like look for is for patients with bone metastases. Cabo is sort of like my go-to drug, because I sort of said, okay, we have good data for Cabo and bone disease. And yes, these are small numbers, but it reassures me that yes, it does have a good benefit for patients with bone disease as well. And again, you can see that the benefit, for patients who don't have bone metastases, the outcomes are much better. So again, reaffirms that even in the era of VEGF-IO combinations, bone metastases actually have poor prognosis compared to what we know from before. So it doesn't really change my opinion. It just reassures me that this combination is very effective for the subgroups of interest. I know the numbers are really small, but what I really was curious to hear both of your thoughts are, for patients who had prior nephrectomy, understanding that these numbers are small, the PFS was significantly better if you had a prior nephrectomy versus you didn't have a prior nephrectomy. And it's hypothesis provoking. I know Alka is doing a SWOG study in the same setting, but looking at this data and I'm curious to hear your thoughts on, if a patient has low volume disease, would you sort of like advocate for a prior nephrectomy given what you saw here in terms of PFS benefit?
Brad, what do you say to that?
I think we've seen this across the board. We look at the data for Pembrolizumab, Cabo Nivo. We've seen that the presence of the kidney in place is even with Nivo Ipi associated with worse outcomes. I really feel that probably is more of a prognostic marker than a predictive marker, that these patients have rapidly progressive disease and they went right on a trial without nephrectomy because they weren't fit enough to do that. And so I don't necessarily know how. I take this more as a prognostic marker, really highlights in the IMDC criteria. I think that time from nephrectomy to systemic treatment, like under or over a year, we've seen like if it's over 2 years, it's even better. Really highlights the prognostic role. But I will think about, nephrectomy, if they have low volume disease or symptomatic, or if I can remember maybe potentially even disease-free with like nephrectomy plus radiation, I certainly think about in the upfront setting. And I really do think about a consolidated nephrectomy. So if I do patients and they get therapy for 3 months and they're doing really well, but their kidney's still present and that's really the only side of disease, I'll often talk to my surgeons about thinking about a consolidated nephrectomy, given what we've seen with the CERTIME data.
Yeah, I think that we get this question all the time for patients, right? What about my kidney? When will my kidney come out? And based on what we have now learned, my practice is also to start them on systemic therapy. And if they have a really great response elsewhere, then talk about a consolidative nephrectomy if needed, or if the patient is really keen and, So this is really exciting to see all these, subgroup analyses and reassuring data for sure. Now we'll come to a final abstract, which I'll introduce here. This is the phase 2 IMvigor210 study cohort 1, which led to initial accelerated approval of atezolizumab as a monotherapy in cisplatin ineligible patients as first line. And this is the 5-year response and survival analysis, as you both know, and as everybody in the audience knows. The cisplatin ineligible patients have had multiple treatment options over the past few years. Initially, Carbo-Gem was the preferred regimen, and when Atezo and Pembro were approved in this setting based on duration of response, that was really very exciting. And then based on the phase 3 confirmatory studies, it was found that single agent immunotherapy is not as good as carboplatin, and the FDA restriction came out in the PD-L1 positive patients, or patients who are not eligible to receive carboplatin. And more recently, we saw that pembrolizumab is now using, based on the FDA full approval, it is only recommended in patients who are fully platinum ineligible. So in that context, this is a 5-year response and survival analysis. And so just as a quick intro in this, the confirmatory trial was the phase 3 IMvigor130 study. where they compared the chemo and atezo combination to atezo alone and then chemo and placebo. And in this cohort, this was primarily the cis-ineligible patients. They received atezo every 3 weeks. Primary endpoint was objective response rate, and secondary endpoints were duration of response and overall survival. And they also looked at PD-L1 high subgroups in this. Around 120 patients were evaluable, and this is a long follow-up of around 5.8 years minimum. So the median duration of response was 5 years in all comers. And in the high PD-L1 subgroup, it was not yet reached. So the authors conclude that in this 5-year clinical update, durable responses and long-term survival were seen, and the median duration of response was not reached. In my opinion, yeah, this is important, but the field has also since moved forward with the Javelin Bladder 100 trial showing that gem-carbo followed by avelumab maintenance in patients who don't progress really leads to tremendous survival improvement of 7 months compared to best supportive care. And we have also learned that PD-L1 is not really a very predictive biomarker as from the Pembro study. However, in the exploratory analysis from the IMvigor 130, high PD-L1 subgroup patients did have better responses, but that was exploratory analysis. So in my opinion, for cisplatin ineligible, I would go with gem-carbo, followed by avelumab maintenance. Would welcome to hear what you think, Brad, for this study. Does it change your current practice pattern or reassure you?
I mean, I think this highlights what we already know, that when immunotherapy works in urothelial carcinoma, it can work really well. And if you are fortunate to respond, you're going to have that great prolonged response. The question is, who are those patients? And how can we select for those out of those patients? And now that we have like the phase 3 Javelin data, which says, start with chemotherapy. And if you, as long as you respond to therapy, stable disease or better, you can do maintenance PD-L1 therapy with avelumab and get this improvement overall survival. Or if you progress quickly, you can go right on to immunotherapy. It is a little bit of a paradigm shift. And so, I mean, I think this is certainly really reassuring, highlights the durability of responses of immune checkpoint blockade. But for me, I just don't know. It's always challenging. Who is that patient who's going to respond to immunotherapy and not going to respond to platinum upfront, and how can we sort those out? And we just don't know. And so in the absence of knowing that, I am, like you, I'm trying to get that initial platinum doublet in for 4 cycles, and then moving on to a maintenance avelumab approach.
Yeah, and that's a great point, because we saw in the phase 3 study that there were early deaths on the immunotherapy alone group. I mean, eventually the survival curves catch up, but we only get one chance to do it right, in my opinion. Deepak, how do you approach your cisplatin ineligible patients, and where does this follow-up data take you for any changes to your practice?
So I agree with both that the survival, I mean, there's a subset of patients that respond really well, and those patients, unfortunately, we don't know how to identify them. And as we all know, in bladder cancer, patients can go down very quickly or go down south very quickly. So I think picking the best regimen is sort of what I think we should all do, and gem-carbo followed by maintenance avelumab is what I've done. There are some patients that are completely platinum ineligible. I mean, for those patients, I ask myself, what's the next best option? I think for patients who are completely chemo ineligible, I think immunotherapy is a good outcome, a good option. And those patients, again, there's a 20% response rate upfront. And again, these patients, if they do respond, have very good long-term outcomes. But I also do think that the field is evolving too rapidly. I mean, we know that gem-carbo avelumab is now what is considered standard of care, but EV 103 cohort A, which looked at EV plus pembrolizumab, I mean, the response rates are 73%, the disease control rate of upwards of 90%, and cohort K is closer to completion. So I think that will probably cement the role of EV probably in a frontline setting for these patients. There was data at this meeting that looked at erdafitinib plus sertralimab. Obviously, that was in platinum refractory patients, but you could argue that the investigators might actually try to move that in the same space as what we're talking about right now, because their also response rates seem to be very impressive, at least to me.
Yes, that is a great perspective. The field is rapidly evolving, and it's good to keep this progress going. I believe this brings us to 5:30. Do you have any parting thoughts for our audience, Brad, Deepak?
No, I mean, I think I agree. I think, as Deepak said, the field is evolving rapidly, both in urothelial and renal cell carcinoma. When you look at renal cell carcinoma, seems like every meeting we have a plenary now. If pembrolizumab was in the adjuvant space, how does all this data going to play in the new frontline setting as urothelial, as important moves up? So I think certainly data just keeps coming out, and it's great. We're going to get multiple new options, and everything we thought we knew 6 months ago is going to change as we get the next big study.
Absolutely, and these are really great times for investigators and patients likewise. Jen, I believe we are on time here.
Yes, definitely. Is any other things that you want to share with the audience before we close this out? No, thank you so much, Dr. Gupta, Dr. Kilari, and Dr. McGregor for your expertise tonight. I always learn so much from these, and I'm sure I can speak for the entire audience in saying we appreciate your time. We appreciate your expertise. To the audience, thank you for joining us for tonight's panel discussion. The replay of this discussion will be available on LARVOL's YouTube channel. And if you'd like, you can join us for more of these discussions following ESMO, and we will have some others also following SITC and the San Antonio Breast Cancer Conference and ASH coming up in November and December. So thank you again so much for joining Sunday evening, and have a great day.
Thank you. Have a good night, Brad, Deepak. Thanks, Jen.
Thanks.
Bye.
Thank you. Bye-bye.